All right. Thank you all for coming out. My name is Nate. I'm one of the medicine chiefs. Thanks everyone for being here. I'm going to be helping with Grand Rounds this year. So today I'm very excited to introduce Dr. Meena Rana. So Dr. Rana completed her internal medicine training at the University of Michigan, followed by an infectious disease fellowship here at our very own Mount Sinai. She's the director of transplant infectious disease here at Mount Sinai Hospital. Her clinical research areas focus include CMV, COVID-19, and HIV-to-HIV organ transplantation. She's been actively involved in the Hope in Action study since 2017 here, and we'll be speaking about HIV-to-HIV transplantation today. So please join me in giving Dr. Rana a warm welcome today.
Thank you so much for having me. I'm really honored to be here. And I'm really excited to speak to you about something that's really dear and close to my heart. And that is increasing access and offering hope, HIV to HIV transplantation. I have no disclosures. So our objectives today are to identify people with HIV who should be referred for transplantation, to demonstrate how HIV to HIV transplantation increases access to transplant, and to review outcomes to date for HIV to HIV kidney and liver transplantation from the Hope in Action study. So I want to start out our conversation today by framing this in the larger picture. We have a severe organ shortage in this country. I think many of you know that there's greater than 100,000 people on the national transplant waiting list, and many people die each day waiting for an organ transplant. Every 8 minutes, another person is added to the transplant wait list. And unfortunately, there are more people on the wait list by organ compared to transplants done each year. This is despite the fact that in 2023, we had a record number of 46,000 transplants performed. Now I want to frame the conversation looking at people with HIV. How does the organ shortage affect patients with HIV? And to really do that, we have to look back at our history. So I'm going to talk first about the history of HIV and organ transplantation, and then I'm going to talk about negative to positive transplantation, and by that I mean using negative donors for HIV positive recipients. And then we'll talk about positive to positive transplantation, meaning HIV positive donors for HIV positive transplant recipients. So first, let's go back to the 80s and the 90s, when pre-ART transplantation in people with HIV resulted, unfortunately, not surprisingly, in poor patient and graft survival. And US legal code in 1988 was amended to prohibit transplantation of tissues from HIV positive donors. This was to prevent the inadvertent transmission of HIV from positive to negative recipients. As you can see below, this unfortunately did occur. Since the advancement, however, of antiretroviral therapy in the mid-1990s, mortality in people with HIV become really related to other causes, right? Like kidney disease, cirrhosis, cardiovascular disease. But in the early 2000s, despite this, concerns regarding infection, death, and allocation of a scarce resource, like I talked to you about, persisted. And in the early 2000s, studies looking at people with HIV show that they continue to have disparities in access to transplant. I'm going to talk mostly about kidney transplant today because that is really where the need is the highest, and that's really where we do the most organ transplants. You can see in this study that the likelihood of a patient with HIV getting a kidney transplant was significantly lower than a patient without HIV. And unfortunately, in this study, HIV-positive waitlist candidates were more often young, male, African-American. They had a longer time on dialysis, and they were more often co-infected with hepatitis C. And unfortunately, HIV and kidney disease continues to remain a significant challenge. The risk of AKI and CKD remain higher in patients with HIV when compared to the general population. This is a study by Dr. Nadkarni and Dr. Wyatt, and you can see that in terms of patients with HIV who are hospitalized, they're more likely to have AKI requiring dialysis as opposed to people without HIV. And nowadays, the terms of CKD that we're seeing in patients with HIV, it's really less related to things like HIVAN, right? But more related to comorbidities like diabetes, hypertension, hepatitis C. Unfortunately, patients with HIV who remain on dialysis have been shown to have a worse prognosis as compared to people without HIV. So I want to transition now to talking about the initial multi-center study that looked at negative to positive HIV and organ transplantation. And this was the first study that really showed that negative to positive transplantation was feasible in people with HIV and had good outcomes. So the history behind this was that in the early 2000s, investigators received NIH funding for the HIV-TR or transplant recipient study. This study was conducted from 2003 to 2009 at 19 US centers and enrolled 150 kidney and 125 liver recipients. And the inclusion criteria for this study are important because they continue to guide inclusion criteria and clinical care today. For this study, kidney candidates have to have a CD4 count greater than 200, a suppressed viral load on antiretroviral therapy. Liver candidates had to have a CD4 greater than 100, and the lower threshold was used to account for sequestration due to hypersplenism. An active OI was considered an exclusion. Prior OIs, including PML and visceral KS, those two specifically were considered exclusion, and lifelong PCP prophylaxis was recommended in these patients. What were the early outcomes of the initial negative to positive kidney transplant study? Well, you can see that study patients had excellent patient and graft survival. At 1 year, there was 95% 1-year survival, and at 3 years, there was 88% survival. Graft survival at 1 year was 90% in patients with HIV, and at 3 years, 74%. So this was really the first study to show that patients with HIV could be transplanted successfully. These findings were published in the New England Journal of Medicine, and I want to take a moment to pause and remember Dr. Barbara Murphy. Barbara Murphy was our previous chair of medicine. She was the site PI for this study. And Barbara Murphy was a huge advocate for HIV and organ transplantation. And I found this quote attributed to her, and I think it's really meaningful when we talk about HIV and organ transplantation. She is to have said, quote, as if there were a moral hierarchy when it came to donor kidneys. So what are some of the lessons that we learned from these initial studies around negative to positive transplantation? Well, this fear, right? This fear that if we transplanted patients with HIV, they would become even more immunosuppressed and we would see more infections. That did not really occur. We did not see that in those studies. There was no uncontrolled HIV. As long as patients continued to take their antiretroviral therapy, they did very well. What did we see in the initial negative to positive studies? Well, we saw, unfortunately, a higher than expected rejection rate. At 1 year, 31%, and at 3 year, 41%. And this is higher than compared to patients without HIV. And the study authors are quoted to having said, quote, the greatest clinical challenge was achieving therapeutic and non-toxic levels of the immunosuppressive drugs administered, owing to the complicated pharmacokinetic interactions of these agents with some antiretroviral agents. So I want to now spend a little bit of time talking about these factors, rejection and the drug-drug interactions. So first, let's talk a little bit about rejection. Why are the rates of rejection higher in patients with HIV, specifically after kidney transplant? Well, that still to this day remains unclear. The thought is that perhaps there may be a chronic inflammatory state or immune dysregulation secondary to HIV. Some of the initial thoughts were we too scared to immunosuppress our patients with HIV? Was there suboptimal use of anti-rejection medications? And in fact, the use of antithymocyte globulin or T-cell depleting therapy in the initial HIV-TR study was associated with increased infections and mortality. What about the use of protease inhibitors as a class of ART? In the initial HIV-TR study, it was shown that patients who received protease inhibitors had a really difficult time managing their tacrolimus levels after transplant. Did that result in higher rates of rejection? So this was a subsequent study published in 2016 looking at the use of induction immunosuppression in 830 kidney recipients with HIV. And you can see this was based on SRTR or transplant registry surveillance data. And basically there was no increase in infections and the different types of infections by the different types of induction therapy. However, there was a reduction in rejection for patients who did receive induction immunosuppression. What about the drug interactions? Well, for patients with HIV who are on a PI like ritonavir or cobicistat and then go into transplant, they actually need very, very low doses of tacrolimus. And the thought is that because they're only getting 0.5 to 1 milligram of tacrolimus a week, this may result in a variability of tacrolimus exposure after transplant. And so the concern is that that perhaps was leading to a higher risk of rejection. So in this study, using SRTR data, the use of PIs was associated with a 1-point-fold increased risk of allograft loss, especially in the first post-transplant year, and a 1.9 increased risk of death as compared to those on a non-PI-based regimen. So these things that we learned from the initial studies around negative to positive transplantation have resulted in guidelines that are published by the American Society of Transplantation for solid organ transplantation in patients with HIV. Patients with HIV should be referred to transplant if they have well-controlled HIV on antiretroviral therapy. For kidney, heart, and lung candidates, their CD4 count should be above 200 with an undetectable viral load. For liver candidates, CD4 count greater than 100, like we talked about, with an undetectable viral load, and they should have no active OI or malignancy. Based on the studies I presented to you, induction therapy with either lymphocyte depletion or an IL-2 receptor antagonist should be used. And lymphocyte depleting induction is recommended for patients with HIV who are at especially high risk for rejection. What about the drug-drug interactions? Well, we know in patients with HIV going into transplant, we try to avoid the use of protease inhibitor-based regimens or cobicistat, and we try to change their ART regimens to the use of integrase inhibitors, which are preferred given the safety profile and lack of drug-drug interactions. And we now know that there is no question people with HIV do better with transplant than dialysis. In this study, the adjusted relative mortality risk among HIV kidney transplant recipients was significantly lower as compared to those patients with HIV who stayed on dialysis. I don't want to forget about the other organs. Of course, people with HIV, unfortunately, are at risk for acute liver failure as well. This is often due to co-infections with hepatitis C and hepatitis B, alcohol, metabolic factors, and unfortunately in patients with HIV who are often co-infected, we see higher rates of acceleration to fibrosis and cirrhosis. The initial HIV-TR study was also done with liver transplant recipients, and transplantation in that study was associated with a survival benefit, especially for HIV liver candidates with a MELD greater than 15. In that study, there were some early concerning outcomes in high-risk co-infected patients with HIV and hepatitis C. But this was largely due to recurrent hepatitis C after transplant, resulting in graft loss. Now, that's really changed because we have direct-acting antiviral therapy for hepatitis C, so we can treat patients after transplant, and really some of those high-risk features that we saw after transplant we don't really see at this point anymore. What about thoracic transplants? So, of course, we know that we do see cardiovascular disease syndromes in people with HIV, such as accelerated coronary artery disease, HIV-associated cardiomyopathy, pulmonary hypertension. That all contributes to thoracic organ failure in people with HIV. Transplantation of thoracic organs is an emerging and important treatment option for end-stage heart and lung disease in people with HIV. However, we just have less experience and data than comparing to abdominal organ transplantation. However, whatever data we do have shows that there's been equivalent survival for people with HIV and heart and lung transplant as compared to those without HIV. So I've spent some time now talking about negative to positive transplantation, and you can see that the number of kidney transplants and the number of liver transplants in people with HIV has gone up over the years. But coming back to my initial question about the organ shortage, how do we expand the donor pool to account for these increased numbers? So for that, we had to turn to South Africa. For those of you who don't know her story, I encourage you to read it. This is Elmi Mueller. She was a surgeon in South Africa, a transplant surgeon. The Lancet described her as, quote, bending rules, changing guidelines, and making history. And she truly did do that. Her story is that she had patients with HIV and kidney disease. She could not offer them dialysis because of lack of resources. And so she transplanted them. And she was the first in the world to use HIV-positive donor kidneys for her HIV-positive recipients. She published her findings in the New England Journal of Medicine from her first 27 patients with HIV who received kidney transplants from HIV-positive donors. And she showed excellent patient and graft survival. And the race was on to then try to do this in the United States. Again, this comes back to the fact that we have a huge organ shortage in this country. And if a patient with HIV gets an organ transplant, that moves everyone up on the wait list. So recall that I told you it was illegal to use HIV-positive donor organs in this country. So in 2013, President Obama signed the HOPE Act into law. This was the HIV Organ Policy Equity Act, and allowed us in this country to start doing HIV-to-HIV organ transplantation. These are some of the milestones in HOPE Act implementation. You can see that the Department of Health and Human Services in 2015 amended the final rule to allow for recovery of transplantable organs from HIV-positive donors. UNOS and the Organ Procurement and Transplantation Network instituted policy changes and safety measures to allow for recovery and transplant of HIV-positive donor organs for HIV-positive recipients. And in November of 2015, the NIH published HOPE Safeguard and Research Criteria to guide research for HIV-to-HIV organ transplantation. And so the HOPE in Action study was born. The purpose of the HOPE in Action study was to learn if the use of HIV-positive deceased donors is safe and effective in the US. And HIV-to-HIV organ transplantation to this day remains under research. What was the study design? Well, just as I spoke to you about the negative to positive HIV-TR study, recipient eligibility for the HOPE study mimicked that. So CD4 had to be greater than 200 for kidney, greater than 100 for liver. You had to have an undetectable viral load and be on a stable antiretroviral regimen with no evidence of an active OI and no history of PML or CNS lymphoma. And eligible HIV-positive kidney or liver candidates would then receive either a negative donor organ or a positive donor organ. And the purpose of the study was to look to see what the outcomes were. What were the endpoints that we were looking at in the HOPE in Action study? So the primary endpoint was patient survival. Secondary endpoint was graft survival rejection, as I pointed out to you in the negative to positive study, and we know that patients with HIV have higher rates of rejection. We wanted to see if using an HIV-positive donor organ would change that. What about graft function and HIV-associated organ disease? Would using an HIV-positive donor organ impact graft function after transplant? HIV breakthrough, would we see a positive HIV viral load in patients with HIV who received a positive donor organ? AIDS-defining illnesses, cancer incidence, and changes in antiretroviral therapy. Who were the HOPE donors? So the only contraindication to using an HIV-positive donor for the HOPE study was that they could not have an active opportunistic infection. And that was to obviously avoid the transmission of an infection from a donor to a recipient. However, unlike recipients, for donors, there was no viral load cutoff, and there was no CD4 cutoff, and that was intentional in order to maximize the use of these donors. A pre-implant donor organ biopsy was required as part of the study, and the hospital had to be able to describe an effective post-transplant antiretroviral regimen for the recipient at the time of transplant. In 2016, the first HIV to HIV kidney and liver transplants were done. And subsequently, HIV to HIV transplants have been being performed at multiple transplant hospitals, including here at Sinai. So again, what were the requirements for a transplant hospital participating in HOPE? Well, as I already mentioned, the study team had to be able to describe an antiretroviral regimen for the recipient, but the transplant hospital also had to have an established program of care for the HIV-infected subject. They had to have HIV program expertise on the transplant team, and they had to have experience, specifically experience with 5 negative to positive HIV organ transplants. And of course, they had to have an IRB-approved research protocol doing HIV to HIV organ transplantation. Over the last 8 years, as you can see, the Hope and Action transplant hospitals have expanded. There are now 35 transplant centers in the country performing HIV to HIV organ transplantation. What about the OPOs? These are the organ procurement organizations that are responsible for procuring HIV-positive donor organs. As you can imagine, this was new for them too. They needed additional training on how to talk about words like CD4, HIV viral load, antiretroviral therapy. There were challenges regarding privacy interests, right? How do you deal with a family member who may not be aware of a donor's HIV status? And of course, I'm going to talk a little bit more about this, and that is the lack of individuals with HIV who are actually registered as potential organ donors. You can see that the number of OPOs has increased over time. Next, I want to talk a little bit about who are the HIV-positive donors that we see as part of HOPE. Well, initially, back in 2016, what we thought was that we would see basically like 2 types of donors. We thought we would see what we called a lower risk donor, which would be someone who had an undetectable viral load and was on antiretroviral therapy. And then we thought we would see a higher risk donor, which was someone who perhaps had drug resistance mutations. And the concern was, would then that be transmitted to an HIV recipient and result in a super infection? So what did we actually see? Well, one of the unexpected benefits that we've seen are we've had HIV false positive donors. This study looked at the first 10 HIV false positive donors as part of HOPE. You can see that they had a false positive antibody result or a false positive HIV NAT result, but a negative confirmatory result. Previously, these donor organs would have been thrown in the garbage because they had a positive HIV test. But now we can use these organs for our patients with HIV. Who were these HIV false positive donors? Well, they were young donors. They had a median age of 24. They were good quality donors, and these organs were transplanted to 21 recipients with no instances of death, graft failure, HIV viral breakthrough, or OIs post-transplant. And as you can imagine, we screen thousands and thousands of donors yearly, and if an HIV positive assay has a false positive rate of 0.1 to 0.3%, you are going to pick up some false positive HIV tests, around 50 to 100 donors a year. Those donor organs can now be allocated to our patients with HIV who are waiting for a transplant. This looks at the HOPE donors to date. You can see in 2023, like I pointed out, there were 16 false positive donors and 35 true positive donors. There have been 250 donors that have donated 400 transplants, 300 kidney, 90 liver, and 1 heart, which I'll talk about later. This is another study looking at the HOPE donors from March 2016 to March 2020. There were 92 donors. Again, 1/3 were about false positive. These donors donated 177 organs, 131 kidney, 46 liver. 29% of these donors had newly discovered HIV. So that means that these were young donors who did not know about their HIV status, and at the time of procurement, we learned about their HIV status. 71% of these donors had known HIV. Of the donors with known HIV, 90% were on antiretroviral therapy, and 68% had an undetectable viral load. The median CD4 count was 194, and you can see that these donors now come from every portion of the country. Now I want to turn to talking a little bit about this concern that I brought up in terms of super infection. Did we see drug resistance mutations from the donor in the recipient? So when we first started doing this, when we looked at South Africa, we knew that most of the donors in South Africa were newly diagnosed HIV, were not on antiretroviral therapy, and therefore had low drug resistance. Now that's different from the United States, where we have many donors who were on antiretroviral therapy. And so the concern was, would these drug-resistant mutations in the donor be transmitted to the recipient? So this was a study that was first published out of South Africa. Samples of plasma and peripheral blood mononuclear cells were collected from HIV-positive donors and their HIV-positive recipients. Drug-resistant mutations were found in 6 recipients, but none of these were donor-derived. There was a transient detection of viral inoculum from the donor and plasma samples from 8 recipients, but there was no evidence of a sustained donor-derived, quote, super infection observed. What about in the United States? Well, as part of the HOPE study, total HIV proviral DNA was also extracted and sequenced. We looked at phylogenetic analyses of donor and recipient sequences, and there was no evidence of a, quote, HIV super infection. Longitudinal recipient HIV sequences were collected over 3 years and again showed no evidence of donor superinfection. In one recipient who had a viremic episode due to non-adherence, there was no donor sequences detected. So really the bottom line is that what we've learned in the past 8 years is that we really don't have to worry probably about drug-resistant mutations in the donor because we don't really see them in the recipient. What do we worry about when we're evaluating HIV-positive donors? Well, the one thing that we look at when we get called with these donors is making sure we're not missing an infection. If you remember, I pointed out the absolute contraindication, well, the only absolute contraindication to using a donor was making sure that they did not have an infection. So this was a study that was published, or this was a case report published by Dr. Wolf, of a donor who was a 40-year-old woman whose cause of death was thought to be a stroke. This donor had bipolar disease. She was admitted for confusion and seizures. She was readmitted with headaches, lethargy, and worsening seizures and found to have cerebral edema and brain death, was ultimately referred as a donor, and she had newly discovered HIV. So the ID attending who was on call at the recipient center when they were called about this HIV-positive donors requested an LP and an MRI, which confirmed that this donor had cryptococcal meningitis, and subsequently this donor was declined. So when we are called about these HIV-positive donors, we're not so concerned about drug resistance at this point, but really what we're making sure is that they don't have an infection that can be transmitted from the donor to the recipient. So I want to transition now to talking about outcomes that have been published to date in the HIV-to-HIV HOPE study. So first, I'll start out with kidney. As a reminder, this was a multi-center prospective study comparing negative donors to positive donors for positive recipients. In this pilot study, there were 75 patients transplanted from 14 centers, 25 from HIV donor-positive organs, and 50 from HIV-negative donors. These transplants were performed from 2016 to 2019 with a median follow-up of 1.7 years. So first, again, let's look at the donors as part of this kidney study. So you can see about 1/3, again, of the donors were false positive. Of the true positive donors, the median CD4 count in this study was 300. 5 had a new diagnosis of HIV. 9 were on antiretroviral therapy at the time of procurement, with 5 had well-controlled HIV. 6 were not on antiretroviral therapy and had a median viral load of 183,000. What were the outcomes in the initial pilot kidney transplant study? So you can see that patient survival in both arms was 100%. Graft survival was also greater than 90%, and there was no difference. There was no difference in serious adverse events, no difference in infections. Again, we did not see breakthrough HIV viremia. This initial concern, would we see a positive HIV viral load in recipients, really didn't play out. The low numbers that we saw of HIV viral load in recipients were really due to recipients who had stopped taking their antiretroviral therapy. And malignancy rates were low and also not different in the kidney study. However, just like in the negative to positive study, in the positive to positive study, we did see rejection. Rejection was common, occurring in 50% of the donor-positive arm and 29% of donor-negative recipients. Despite the high rates of rejection, 1-year graft survival, as I pointed out, was still high. And again, when we looked more closely at these recipients who had experienced rejection, we saw that rejection was lower, again, if induction immunosuppression was used. And so this is something that we need to look at more closely with larger numbers. Now, when I first started talking, I told you that patients with HIV had, unfortunately, a longer wait time for transplant as compared to patients without HIV. Well, with HOPE, not surprisingly, that has changed. Within 4.5 years, 70% of HOPE candidates in this study received a kidney versus 43% of non-HOPE candidates. HOPE candidates were more likely Black and publicly insured, and the median kidney wait time was 10 months for a HOPE kidney versus 61 months for a non-HOPE candidate. So when I see a patient in New York who's being listed for a kidney transplant with HIV, I can now tell them that instead of having to wait 8 years for a kidney transplant, hopefully you can wait 3 to 4 years or even less. So at this point, HIV has become almost an advantage for patients going into transplant. I want to transition to talking about the initial multi-center pilot study for liver transplantation from donors with HIV to recipients with HIV. Again, as a reminder, this was a prospective multi-center pilot study comparing negative to positive donors and HIV-positive liver transplant recipients. Again, this was conducted from 2016 to 2019. During that time period, there was 45 liver transplants done at 9 centers, 24 from donor positive and 21 from negative donors, with a median follow-up of 23 months. So let's look at the outcomes here. There were 6 deaths in the HIV positive donor arm, 2 deaths in the HIV negative donor arm. Very, very low numbers of graft failure, very, very low numbers that were not different for rejection in liver. But what did we see? We saw a slightly higher rate of infections in the HIV positive donor arms. In terms of what the breakdown of these infections were, they were mostly CMV, which is something that we see actually in all transplant recipients and is not specific to people with HIV. And there were 6 patients who developed cancer in the donor positive arm as compared to 2 in the negative donor arm. Overall, in weighted analysis, 1-year survival was 83% for patients who had received a donor positive organ and 100% for those who had received a negative donor organ. And so this is something we have to look at more closely. Obviously, these numbers are really, really small. And so in the larger data, when we have more numbers, this is something that we'll have to take a closer look at in terms of specifically how these numbers around malignancy relate to survival. What about the Mount Sinai experience? So here we have a very large experience doing HIV to HIV organ transplantation. We've transplanted 150 patients with HIV through HOPE, 120 kidney transplants and 30 liver transplants. Again, just as I described, we've really seen no HIV breakthrough in our recipients or super infections. All of our patients have undetectable viral loads, as long as they continue to take their medications. And when we're called about these HIV positive donors here, again, we see basically primarily 3 types: false positive donors, donors who weren't aware of their HIV diagnosis, and other donors with HIV who may be well controlled. I don't want to end without talking a little bit about other organs. So the first HIV to HIV heart transplant was performed down the street. From what I hear, this patient is still doing very well, and I think we're going to hear more about positive to positive heart and lung moving forward. I also want to spend some time talking about HIV to HIV living donation. Living kidney donation is possible under the HOPE Act for carefully selected donors. And the first case series of the first 3 living donors with HIV in the US was published recently and reported good donor outcomes at 2 years of follow-up. In this case series, 1 donor donated to her spouse, and the other 2 were non-directed donations who shared that part of their motivation to donate was to reduce HIV-related stigma. For those of you who don't know her, this is Nina Martinez. She's also a staunch advocate for HIV to HIV transplantation. She was the first living HIV donor in the US, and she is quoted to having said that society perceives me and people like me as people who bring death, and I can't figure out any better way to show that people like me can bring life. This was a study that surveyed people with HIV and their willingness to donate. 114 people with HIV were surveyed regarding knowledge and attitudes about organ donation and transplantation. About 71% were willing to be deceased donors as part of this study, but only 25% knew of the HOPE Act and only 21% were registered as organ donors. So we clearly have some work to do there. Most people believe that people with HIV should be permitted to donate organs. and that using HIV-positive donor organs would reduce discrimination. I also like to mention this. This is the only case that I'm aware of, actually, of a positive to negative living donation. This was done in South Africa. And I just want to quote to you what the study authors said here. That quote, "The transplant saved the life of the child who would certainly have died otherwise. Our team is regularly challenged by parents whose children present critically ill with liver failure. We are repeatedly asked why being HIV positive excludes them as living donors." So what are some of the ongoing challenges that we face with HIV to HIV transplantation? Well, unfortunately, we do see a disparity between what we thought in terms of how many HIV positive donor organs there would be and actual donors. So it's really important that we continue to encourage people with HIV to register to become organ donors. And we in the HIV transplant community have to continue to work on reducing barriers at organ procurement organizations so that they continue to procure organs from donors with HIV. And because the hope remains as research only 10% of all transplant centers have the regulatory variance to perform these transplants. As you can imagine, transplant centers who are doing this have to have a research protocol, they have to have research staff, and there's research costs. And so perhaps this has been a barrier to sort of expanding this and making it more and increasing access to HIV to HIV transplant. In addition, there's an experiential requirement that's still required, 5 negative to positive transplants. And so centers that don't have this experience requirement aren't also able at this point, currently, able to conduct HIV to HIV transplantation. So what is the future? Well, based on favorable results of the first HOPE Act kidney and liver transplant trials, a federal advisory committee made a recommendation to the Secretary of Health and Human Services to remove the research restriction for HIV kidney and liver transplant to outside of research and to make HIV to HIV kidney and liver transplantation standard of care, and to revise the research restriction for other organ types like heart and lung to increase the scope of this practice and to identify more donors. Unfortunately, we are still waiting for an answer from the Secretary of Health and Human Services to see if this is adopted, and so hopefully that will come soon. In conclusion, organ transplantation is the standard of care for patients with HIV and end-stage renal or end-stage liver disease. Refer your patients early for transplant and consider a center who's experienced with HIV to HIV transplantation, like here at Sinai. And initial outcomes for HIV to HIV transplantation in liver and kidney recipients are promising with good graft and patient survival. I have to give a special thank you to my transplant ID team, with whom I could not do this. The Recanati Miller Transplant Institute, specifically Dr. Florman and Dr. Lerner, who've been big advocates of HIV to HIV organ transplantation. The RMTI research team, especially Brandy Hadel, who I think we've consented hundreds of patients together for HIV to HIV transplantation, and the Hope and Action team nationally, specifically Christine Duran. Thank you, everyone.